Mr. Chairman, ladies and gentlemen, dear colleagues, again to express my sincere gratitude for the fantastic organization of this prestigious meeting and the gracious hospitality of our hosts. I decided to present you for this opening session a topic that covers surgery and a very strong element of ethics in surgery. And that covers my two roles as a transplant surgeon and also as a clinical ethicist. For many, many years, I had the honor to chair the Clinical Ethics Committee of Imperial College Healthcare NHS Trust and the Ethics Committee of the British Transplantation Society, and I have done a huge amount of work for the Research Committee, Ethics Committee of the Ministry of Defence, and recently the Ethics Committee of the Police Force in the United Kingdom. And I always strongly believe that surgery must be practiced not only with a very strong code of outstanding clinical practice, but with a very strong code of clinical ethics. And transplant tourism, a wound that we must heal, is one of the disgraces of the field of transplantation, which I have the honor to serve for many, many years. And it's something that we must stop and we should stop, and that's what we are going to talk for the next 15, 20 minutes or so. Medical tourism, and by medical tourism, we mean the need of people to move from their home country to another country to seek health care, worth overall per year around the world, and this is WHO data, 50 billion euros. And in the vast majority of the cases, is perfectly justifiable and is being done in the most appropriate conditions. But there are situations where it's not justifiable and is being done in a shameful way, especially in the field of transplantation. And I will give you two contrasting examples. The first one is for a 35-year-old patient with end-stage renal failure for more than 15 years, possibly due to autoimmune disease, 2 previously failed transplants from a deceased donor, highly sensitized, not doing well on dialysis and running out of vascular access for dialysis, married with a father of 2 young children. His father is 65, he's very well, keen to donate his kidney to his son. Both his kidneys have 3 renal arteries and 2 veins, a very complex vascular anatomy. They are also blood group incompatible, and the cross-match between them is negative. They have been turned down in their home country as too high risk for transplantation, and they have been referred to your expert center, someplace in Europe, for a second opinion and an elective transplant, and they will cover their expenses themselves. Is this transplant tourism? It is. Are you going to accept this referral? I think that we should, and we have a duty to accept it. And is it justifiable and ethically acceptable? I think it is perfectly justifiable and ethically acceptable because you have a very complex medical situation and cannot be treated in the home country, and they are asking for advice, expertise, and support in a more advanced health system. Not only we can't do that, we have a duty to do that. But look at this example. And these are real-life examples. A 28-year-old male patient from an ethnic minority in the United Kingdom with a known cause of end-stage kidney failure, on hemodialysis for 3 years, doing well, no other problems, on the waiting list for a kidney transplant with no kidney offers so far. He is married, he is the father of a 2-year-old daughter, and his wife is pregnant. He hates dialysis that makes him feel handicapped and shameful. Upon the advice of the elder members of his family, he borrows money from a credit card with a very high interest rate, of course, and goes abroad to get a kidney transplant. The transplant fails due to renal vein thrombosis. Following the removal of the kidney, he develops an abscess in the right iliac fossa, and he is treated with industrial doses of antibiotics that make him eventually deaf. After he runs out of money, they send him back to the United Kingdom. He collapsed at Heathrow Airport, and he was transferred urgently to the Hammersmith hospital. He was very septic, had multi-organ failure, and I did a laparotomy on him to evacuate 4 liters of pus from his abdomen. He died a few days later in the ITU. Is this transplant tourism? It is. Is it justifiable and ethically acceptable? Absolutely, categorically not. And what was even more tragic is that when he was dying in the ITU, there are about 10 brothers and sisters outside grieving. They should be there when he actually needed a kidney. So what is the problem? What leads people into these desperate solutions of going abroad, and buying kidneys, basically? There is an increasing number of patients required solid organ transplantation, undisputably. And there is lack of available organs. So the shortcut solution to cover the gap between supply and demand is transplant tourism. And you can see that just in the UK, 7,500 people are on the waiting list for a kidney transplant. There is a 70%, 70, increase over the last 10 years, and 3 people die every day, 1,000 people per year, waiting for a kidney transplant. So these desperate people are seeking treatment through transplant tourism. The waiting times for a kidney transplant in the UK, the average is 3.2 years. But if you look at ethnic minorities who are blood group B and AB, and they have very difficult tissue types, it can be much, much longer. Sometimes they wait forever. In Canada, another quite advanced country in healthcare, it is anything between 2 and 6 years, so a pretty long period of time. Where does it happen? Where do these people go desperately looking for a kidney? Basically, is in Asia. China being the main provider of it, with 60% of Malaysian transplants, for example, being done in China between 2000 and 2010. The Philippines, Pakistan, India, Colombia, Somalia, and other countries not well developed at all join this chorus, this litany of countries providing this kind of treatment, quote unquote. What are the characteristics of transplant tourists? And these are some fantastic papers published by the Canadians, and I would strongly advise you to read them because they're an epitome of how a paper should be written robustly, openly, and honestly. And you can see here that over the last few years, it has doubled the number of people from their program that they're going abroad seeking for a transplant through transplant tourism. And it's approximately 10 to 15% of their overall program. So it's a pretty significant number. And most of these people going back to their countries of origin to seek a kidney transplant. And again, it's the same category of countries of China, India, the Philippines, Pakistan, Iran, and other countries where they go back to have a paid kidney transplant. What are the characteristics of these people who go abroad asking for a kidney transplant? They are middle-aged usually, no difference between males and females. Usually they get a kidney from a living donor and sometimes from a deceased donor, hopefully somebody who died not because he was supposed to be a donor, but he died by accident, and in a big number of cases, totally unknown. The time they wait on dialysis is small, and this is the advantage. This is the candy. They don't have to wait that long. They get off dialysis pretty quickly. And as you can see, their ethnicity is predominantly Asian or South Asian. The characteristics of these transplant tourists, and this is again from the Canadian paper that shows as to why these people went abroad to buy a kidney. And I call this kind of graphic in this paper as the history of lost opportunities. In this Canadian program, 93 people went abroad for transplant tourism, to buy a kidney abroad. From these 93 people, when they are in Canada, 28 people were not referred for transplantation altogether. 65 of them referred for transplantation. 13 of them were never assessed. 52 had an initiated transplant assessment. 33 out of these 52 had a potential live donor that never materialized. And 21 of them had they don't have a complete assessment. And finally, only 31 of them, only 1/3 of them, had a complete assessment and ended up on a proper waiting list. So this is not a failure of the patients. This is a failure of a system, and even advanced healthcare system. You can see here a meta-analysis of cases that have published the data comparing people who were transplanted through transplant tourism versus people who were transplanted in their country of origin. There is a bunch of 20 studies with quite a few hundred of patients on each arms, published not too long ago in Clinical Transplantation, and covers the period between 1983 and 2008, so a quarter of a century, which is pretty significant. And if you see the comparison of the data in every single of those studies, when it comes to technical complications, infections post-transplantation, developed of post-transplant lymphoma, patient and graft survival, undisputably, the patients who had their transplants properly in their countries of origin had superior results compared to patients who went abroad. And even if you pull all the studies together as one big trial, again, the same stance. The patients who had their transplants at home had much superior results compared to the patients who went abroad. And this stands for technical complications, infection, cancer, patient, and graft survival. An even bigger problem is when these people, if they go, for example, from the United Kingdom abroad to buy a kidney and they come back and the whole thing falls to pieces, we have the system to pick up these pieces. But if they come from a country like, for example, Kosovo or Skopje or Albania and they go abroad and they come back, they don't have the system to pick up the pieces and help them. And look at this absolutely catastrophic cohort of 36 patients from the Balkan area that went to Pakistan from a kidney transplant and they came back. Mortality of almost 25%. 25% mortality in a live donor kidney transplant program. If this happens in the UK, not only do you lose your license, they will put you in jail and they will throw the key away. And look, beneath that, the litany of catastrophes: wound infection, hematoma, perineal abscesses, lymphocysts, urinary leakage, renal artery thrombosis. The list goes on and on and on. There is no surgical complication in the book that they didn't have in very substantial percentages. An absolutely and total catastrophe. Also, you see in these patients some really nasty infectious complications that we don't usually see in an advanced transplant program. And you can see here 19 episodes of really nasty fungal infection in 17 patients, the whole lot, with very horrible and significantly lethal complications. Now, the donors, the people who donate those kidneys to those who go abroad to buy a kidney. The workup of these people, it doesn't exist. There is no even one published guideline, one piece of paper someplace to say that these people have even the elementary workup before they go ahead and they donate their kidneys. The facilities where this happens, this is photographs from real places where these things take place. Most animal laboratories have better facilities than that in the Western world compared to what is happening in places like those clinics, quote unquote. The surgery, if you can call this surgery, look at those scars. You wouldn't even use this kind of technique and way to close a pig after surgery, let alone a human being. And if this is what is happening in the outside, you can imagine what is happening in the inside regarding the quality of the so-called surgery. Crimes, very well documented crimes, especially in the Balkan area where murders took place for the retrieval of those organs. Absolutely horrible. The outcomes, the medical follow-up of these donors, what happens to these people once they donate their kidneys, it simply doesn't exist. Something that is our paramount duty of care in the West, it simply doesn't exist. The socioeconomic survey of kidney vendors in Pakistan, this is an absolutely amazing study that followed 239 patients in Pakistan that they donate their kidneys through transplant tourism. They sold basically their kidneys through transplant tourism. They are predominantly young people, predominantly male, and they have a very big family. The vast majority of them are totally illiterate or have a very, very basic education. And when you see to their occupational status, the vast majority of them are in bonded labor. They are basically slaves. And if they are not slaves, they are not far from it. So a very, very, very sad cohort. And if you see the socioeconomic status of these patients in a little bit more detail, the vast majority of them were making just a few dollars per week. Big families, as I said, and the main reason they were donating their kidneys is to pay debt. So they were not even making some money out of this. They were just trying to go out of debt, which was usually at the level of a few $1,000s. They were being paid, as I said, anything between $1,500 and $3,000 for donating their kidneys, which is the price of a very bad used car. So totally shameful situation. And this, look at this, which is even more shameful. So the average price, what they have agreed to be paid, was $1,700. What they actually received was even less than that, because they had, the absolute, horrible situation that they had to pay for their own traveling and accommodation expenses, even from this tiny fee. If you see the amount of money that was being paid by the recipient for this transplant overall, this was anything between $40,000 and $300,000. So even if you get the small end of the scale, $40,000, from this $40,000, only $1,300 ended up in the pocket of the donor. The rest of it went not even to the medical team, if you can call it this way, went basically to brokers. A totally shameful and unacceptable situation. So transplant tourism not only cannot be justified, it's totally ethically, utterly unacceptable for the following reasons. Number one, human life is not for sale. The human body and human life are sacred. And if even those are for sale, I don't know what is left to believe in and fight for. Secondly, this kind of donation, quote unquote, is the product of coercion and even more, most of the times, criminal activity. People say frequently when I debate this issue about paid donation that it's a matter of autonomy. People have every right to sell their kidneys. They are autonomous human beings and they have every right to sell their kidneys. What hypocrisy. You saw who are these people who are selling their kidneys. They are people in bonded labor. They are slaves. The autonomy of slaves. This is either the joke or the oxymoron of the century. Also, a few euros or dollars or any other kind of currency that they will make will not save this actually vulnerable individual. Actually, it gets them into a deeper and darker hole because they are only used to pay part of their debts. And on top of this, most of them get into very, very serious health problems. And also, this kind of donation destroys forever the miracle of transplantation and the gift of life, which is the great motivation for the huge and the vast majority of the donors. And if we accept this kind of donation, it will discourage the huge amount of people who come forward and help really, really genuinely. It is also clinically unacceptable because there is no robust evaluation, preparation, surgery, short and long-term follow-up of the donor. And the same, of course, things stands for the recipient with absolutely appalling, clinical outcomes. It's even financially unacceptable because, if we have in the United Kingdom this species which is called the hospital manager, and the only thing they care about, not clinical care, they care about money actually, and how they are going to save money more than anything else. And they say, okay, it is horrible, it is bad, people go abroad, but listen, by going abroad, they get off dialysis, they save us an enormous amount of money. If you really calculate the cost of taking care of these people when they come back with a horrendous amount of complications, and the fact that most of them, they become not retransplantable and they have to stay on dialysis for the rest of their lives, it's even financially unacceptable because the cost is absolutely outrageous. The Declaration of Istanbul on Organ Trafficking and Transplant Tourism of 2008 states very clearly, the legacy of transplantation is threatened by organ trafficking and transplant tourism. The Declaration of Istanbul aims to combat these activities and to preserve the nobility of organ donation. The success of transplantation as a life-saving treatment does not require nor justify victimizing the world's poor as the source of organs for the rich. Who is to blame? Transplant tourism is unacceptable, but don't blame the desperate patients who are in need for the transplant. Blame those who exploit their desperation and the desperation of vulnerable people in need for some money. And this is happening, these brokers, not in dark corridors someplace, but in daytime, even in international congresses. One of them came to see me in a big American congress to give me his card and offer his services. I will not repeat to you what I told him he should do with himself and his card, because there are ladies in the room, but you can use your imagination. But these people do exist, and it's an utterly shameful situation. And on top of this, we are to blame. We need to do more to be able to facilitate transplantation. Number one, make donation part of our culture since primary school. In the United Kingdom, over the last 5 years, we were able to increase donation by 50% by introducing the presence of organ donation nurses in every single hospital. But we are planning to go beyond that and build up a pro-donation culture as part of the healthcare literacy of people since primary school. Boost living donation, especially preemptive, before the initiation of transplantation, as the biggest gift of life. And again, people will tell you many times, you know something, people don't do it nowadays. They are very egoistic, they are very indifferent. They will never come forward to donate a kidney. When I came back from the States to the United Kingdom in 2000, they told me it will never happen in England. They had only a handful of cases of live donation every year. We managed to go from a handful to almost half of the transplants coming, from live donors, with proper education and proper information to the patients. Advance deceased and living donor sharing schemes, like the Eurotransplant scheme for sharing organs between European countries, and even more the paired and pool living donor schemes for ABO-compatible or highly sensitized patients. Support countries to develop state-of-the-art, robust living donor transplant programs. I think this is the biggest cure, when you can give an opportunity to any country in the world to develop a proper, robust, clean transplant program, properly supported and owned and run by the country of origin. And finally, invest in technology that allows to further utilize extended criteria donors, basically to utilize kidneys that they were supposed to go to the bin, and now they are being used properly for transplantation, which will be part of my presentation to you tomorrow. And a last thought, It is our duty to always think and act creatively, progressively, but also transparently and robustly in order to further promote organ donation and transplantation, and not to surrender our patients and ourselves to the naive idea that the dark forces of transplant tourism can be the easy way forward. Thank you very much for your attention.
Very well presentation, Professor. Anybody who wants to ask the question from Professor, please.
Thank you. Thank you very much for highlighting this important problem. I was sitting on the ethics committee in the UK as well, and I'm fully aware of this problem. But till what you suggest, and I like very much what you suggest at the end, the ways we can improve things forward, but this will take many years. And you, as you said rightly as well, you cannot blame the patients, and we cannot blame the donors as well. So saying that selling human organs is unacceptable ethically, which is right, but we have to accept that as long as there is a need for a patient and there is a need for the donor, it will exist. What I think can be done during the years which will happen till we find donors for every recipient and every patient in need, if we legalize the matter, we can make it much better than what you showed us.
I mean, I will agree with you entirely that we should not blame the patients and we should not blame the donors. I will respectfully disagree in the other two things. First of all, when it comes to the issue of things will take many, many years. Again, as I told you, we managed within a 5-year period in the UK, and as I'm sure you can recall because you have worked in the UK, with the enforce of NHS blood and transplant to increase deceased donation by 50% in 5 years. This is massive.
Yes.
The same thing stands.
Still there is a need.
No, I don't dispute that.
Yeah.
We also managed to increase live donation from nothing to almost half the transplants. So if we push more in a few more years, I believe that we should be able to cover the gap. When it comes to the legalization in the United Kingdom or in any other country of the West, as a matter of fact, the only thing you are going to do is to transfer the problem from someplace else to the UK or America or Canada. Because let's face it, who is going to come forward to donate a kidney? It's not going to be Bill Gates or George Soros or Warren Buffett. It's going to be some poor bugger who doesn't have any other source of money. And what I always say to my colleagues in the UK is if the last thing we have to suggest to the poor as a way to find money in a civilized society is to donate their kidneys, we have failed as a society altogether. So we need to find other ways to support these people and not to legalize, so to speak, the issue just to allow them to do it.
But we have to admit that we have failure in many countries in the world, and we have poor people. And you showed that it pays $40,000 to $300,000, and he's receiving less than $1,000 or less than $2,000. So I think it's unfair. We are adding to the unfairness by let them keep or allowing them to do it in the dark.
Even if we do it in the UK, again, I believe we will just be exploiting the vulnerable, and we should have other ways to help them. And even if we do legalize it, it's my strong feeling that they will only get a very small, share of the pie, that they will not solve any problem. If anything, it create more problems to them.
Can I ask you one question?
Yeah.
It's a very interesting and good discussion we had about the donation. I just wanted to discuss you to legalize or may not be legalized, maybe restrict a little bit, illegal transplantation, or to pressurize the poor to pay to get the money for a small amount of money to give his kidney. What do you think if we restrict this thing only for a live donor who is a very close relative of the deceased, rather than somebody from outside? So in that way, we cannot abuse a poor person that he should sell his kidney for the sake of some money, for the sake of money. But if somebody is close, like a father to son or son to father, Like if that kind of donation, is it acceptable, do you think?
That's a very important point, and I have two things to say. First of all, I'm doing this for a living for the last almost 30 years, and I never met in clinic anybody who told me, you know something, I'm thinking of giving a kidney to my brother, but if it was for 10,000 pounds on top of this, I would do it. It never happens. The greatest motivation for organ donation are the donors. These are the people who come forward absolutely determined to help. It's not the recipient, it's not the surgeon or anybody else. They are the donors. So this argument that we will motivate people more, they won't. They really come genuinely to help. What we have fall short is the issue that we don't recognize our appreciation to these donors beyond the issue of making money. So the only thing we do at the moment as a society is to pay for compensation for travel and accommodation expenses, and for those who are self-employed for the number of days they lost from work. And if you see all the studies in the UK, in America, in Canada, people believe that we should go beyond that. We should give them some extra pension years, for example. We should give them some sort of other social recognition about their good act. Not to go down the road of them making profit in their pocket, but a kind of social recognition as an appreciation of their art. This we have to go a long way before we are up to where we're supposed to be.
Any more questions from the professor after this very interesting and obviously informative talk? Thank you so much.
Thank you.